During this case study, I'm going to talk about COPD, chronic obstructive lung disease, which of course is a respiratory disorder. This image should remind you that with obstructive lung disorders, there is more of an issue with expiration than inspiration. So you can see what happens, this collapse and mucus buildup, all leading to an obstruction by the time the person tries to exhale. Initial history, we have a 62-year-old female that presented to a clinic complaining of shortness of breath. We know that's called dyspnea. And she reports that this shortness of breath has been increasing slowly for years now. In the last few months, her symptoms have become worse. She's also complaining of new onset ankle swelling, which we would call edema. Additional history includes an 80 pack per year smoking history. She does report that she quit 5 years ago, but had smoked for quite some time. No fever, no chest pain. She reports bringing up a little bit, so scant referring to not much, white sputum or sputum in the morning. She denies any weight loss, denies a history of heart disease, tuberculosis, asbestosis, or occupational exposures. She does report, however, that she occasionally gets bronchitis, and how it will oftentimes be treated is as an outpatient with antibiotics. So this, of course, assumes that it's bacterial infection causing the bronchitis. And no known allergies or history of asthma. So really what's important here is the fact that she was a smoker, bringing up some sputum depending on the extent of it, and certainly the bronchitis. But knowing other areas that are denied is also helpful in ruling out other possible conditions. For example, if somebody had reported extensive weight loss, then one of the things that can be brought to mind would be the possibility of cancer. Upon physical examination, mild shortness of breath was noted when the patient was climbing onto the examination table, and you should not have shortness of breath with such little exertion under normal circumstances. Pulse rate is higher than normal, respiratory rate is higher than normal, and blood pressure would be considered hypertensive at the early stage of hypertension. No cyanosis or bluing to the skin or mucous membranes was noted. Mild jugular venous distension was noted while they were sitting. So thinking back to the jugular vein and how with jugular venous distension, it tells us, well, something's going on. There's some backup occurring from blood moving through the heart. The patient is using their accessory muscles while they're at rest, so muscles that you would typically use when you're exerting yourself to help you breathe. This patient is using just at rest, which is not normal. It was noted that she had prolonged expiration with expiratory wheezes. So this would be very common in people with obstructive lung disorders. So prolonged expiration and these expiratory wheezes would be considered signs because they can be objectively observed by the practitioner. Chest percussion was performed, and this is an assessment technique that's designed to produce sounds when the examiner will tap on certain areas of the body. So just as lightly as tapping a container with your hands produces various sounds, you can also elicit certain sounds by tapping on areas of the body. So in this case, tapping on the chest wall will produce certain sounds based on the amount of air in the lungs, and we know that the lungs should have significant air in them. In this case, though, chest percussion was considered hyperresonant. So the lung is, we know, filled with air. The majority is air, and when you percuss, it should give off this resonance. And hyperresonance then can be heard when the lungs are hyperinflated, as we know occurs with obstructive lung diseases. So I'm just going to go back to this to show you that. So here we have air in the lung or in the alveoli, and that should leave normally under normal circumstances. But when we look at COPD, they breathe in this air and then it gets trapped and it can't leave. So the lungs are considered hyperinflated. And so when you percuss them or tap them, you produce more of the sound associated with air than is considered normal. And that's again described as hyperresonance. Another common feature or sign in patients with COPD is that breath sounds can be diminished along with that prolonged expiration. So we can say that the intensity of their breath sounds is reduced. A palpable liver was noted as well as edema in the lower extremities. So let's move ahead for a moment and go back to an image that we've looked at during lecture to understand why that's occurring. So if there is chronic obstructive lung disease present, it's going to be much more difficult for the right side of the heart to pump blood into the pulmonary circulation. So think of chronic obstructive lung disease being a pulmonary disorder or lung disease that we said can contribute to right heart failure. So the right heart tries to pump blood past this obstruction and it struggles. So we have this increase in afterload now that the right ventricle is experiencing as it tries to push blood back. And we know that that's going to also lead to a backup of the volume of blood, which leads to pulmonary hypertension, which also contributes to an increase in afterload that right ventricle has to work against. And the right ventricle will get bigger and hypertrophy to account for the resistance that it's experiencing, but eventually it's not going to be able to handle it anymore. And so the right heart will start to dilate and not be able to pump blood properly into the pulmonary circulation. And so what will occur is this backup, as we know, into the right atria and then up into the jugular vein. And that's where we get that jugular venous distension that was mentioned on the last slide. We're also going to get blood backing up into the liver and congesting the liver, congesting it enough that it can become enlarged and palpable as stated on the last slide. It can also back up, continue to back up, and cause swelling or edema in the extremities, in this case, the feet. So you can see the relationship, of course, between some respiratory disorders and cardiovascular disorders. 2+ bilateral pitting edema was noted. So I talked about or explained what the edema is from, but what is pitting edema? Well, pitting edema, I've explained, is where you apply pressure to, in this case, the ankle or the foot with your thumb, and when you remove your thumb, it leaves the indentation of your thumb. And that tells you that there is fluid that is remaining in the interstitial spaces, so in between cells, sort of pooled within the tissue. Pedal is referring to accumulation of fluid specifically in the feet and the lower legs. Think of a pedal on a bike where your foot goes. Now, what does bilateral mean? That means both sides, and then 2+ references the degree of edema. And so I have an image that will come up here that can show you that. So this is the measurement in millimeters from the pressure that's applied that would leave an indentation. And so we have 1+, 2+, 3+, and 4+. This is obviously extremely severe, but 2+ pitting edema was noted in this individual. So now that we've talked about the history and the physical exam, let's look at relevant diagnostic tests that were done of both venous and arterial blood. Hematocrit, remember, measures the proportion of red blood cells that are in your blood. And so in normal cases, we'd want to see the percentage between 37 and 47, but this individual has higher than normal levels of hematocrit. Well, why would that be? Well, the body is making more blood cells to try and pick up more oxygen because the body is not getting as much oxygen as it needs. And remember that if we have more than the normal amount of red blood cells, that's called polycythemia. And so why does this happen? Why are we producing more? What's the specific reason? Well, one is that the lungs are damaged from the obstructive lung disease. And so the normal exchange of oxygen and carbon dioxide is not occurring. And if we can't properly oxygenate the blood, what returns to the heart is less oxygenated. And when the body identifies that reduction in oxygen, remember we have chemoreceptors that can pick this up, then the body will think, well, what do I do to try to get more oxygen? Well, if I know red blood cells carry oxygen, then let's try to make more red blood cells and maybe that will work. In addition to that, though, The right ventricle that's working against that resistance that eventually starts to fail or not be able to pump as much blood into the pulmonary circulation. If we're putting less blood into the pulmonary circulation and more of it's backing up, then less of it's making it to the lungs anyways to be oxygenated. White blood cell count was normal, so no evidence of infection in this person. Arterial blood. The arterial blood right now in this person is 7.38. And remember that normal should be between 7.35 and 7.45. So the pH at this time is normal in this person with COPD. However, if it drops below 7.35, that would be considered acidosis. Or if it's greater than 7.45, it would be considered alkalosis. And both of those states are very dangerous for the body to be in. Because remember, we need that tight control of blood pH. So if we look at arterial gases, both oxygen and carbon dioxide, we'll see that they do differ from normal in this person. And it should make sense to you. Their amount of oxygen is less than what it should be. I already explained why. Their carbon dioxide levels are higher than what they should be. We talked about that already too. If we are not able to properly let gas exchange occur, then carbon dioxide remains in the blood. And remember that that's called hypercapnia. A bicarbonate test can give an idea of the carbon dioxide levels in a person's body, so higher than normal, as you can see here. Remember that carbon dioxide, when it reacts with water and it forms carbonic acid, it will dissociate and form bicarbonate, which you might recall as HCO3, and hydrogen ions. As a reminder, spirometry is the most common type of pulmonary function or breathing test, and it measures how much air you can breathe in and out of your lungs, but also how easily and how fast you can blow the air out of your lungs. And so a doctor may order spirometry or a spirometry test if they have a patient that has any signs or symptoms of an obstructive lung condition, but that might include just wheezing or shortness of breath or a cough. So let's look at this female's spirometry results. We have a forced expiratory volume in 1 second test, also known as the FEV1. And so what this is, if we look at this simple chart here, when a patient is told to breathe in, so they breathe in as much as they can, fill their lungs, and then they'll be asked to breathe out into the device as hard and fast as possible. And in normal circumstances, so this is representing breathing out, in 1 second you should breathe out a good amount of the air that you breathed in, and then by 3 seconds you've breathed out the majority of the air that you've breathed in. But people with COPD, we know that they have issues with expiration. And so there's going to be a noticeable difference overall in how much air they can breathe out, but with their FEV1 as well. So this means that this patient, this female patient, when she breathed in and then she breathed out, she was not able to breathe out forcibly and completely as much as is considered normal by 1 second or even more seconds after that. So she was only moving 1.67 liters per second, which is 45% of really what she should. Her forced vital capacity, this is the amount of air, so the amount of air that can be forcibly exhaled from your lungs after taking a deep breath possible. So you take in a deep breath and then you breathe it out. And the total amount, so we're looking just at volume here rather than here where we looked at it as a function of time, they were only able to breathe out about 85% of what is considered normal. Okay, that's the end of this case study. Thanks for your time. Bye for now.